It is my pleasure tonight to introduce our speaker, Dr. Sohail Saghezchi. I actually met him when he was very young, in his early 20s, when he was in dental school, when I used to work for his dad, Dr. Sage, 23 years ago. He's a board-certified oral surgeon. He received his DDS from UOB, and after practicing as a GP with his father for 8 years, he went back to UCSF for his internship in oral surgery. He received his MD from the medical school and the oral surgery residency. All the training were at UCSF. Currently, he's an associate clinical professor and residency program director for oral surgery at UCSF. So please welcome Dr. Sohail Saghezchi.
Okay, good evening, everyone. Thank you so much for having me here. It's a real pleasure to be here and see so many familiar faces again. It's actually pretty nostalgic for me because I was a member of this dental society for many years back in the day when I was practicing oral dentistry. And so, to be back here, to be invited to speak here again like this, it's a real honor. I'm very thankful. As previously mentioned, I was actually scheduled to give this talk next month. I got an email from Megan asking me if it's okay if I do the presentation via Zoom. And I said, preferably not. So she said, she contacted me and 2 days ago and said, well, do you think you can give your talk the day after tomorrow? And I said, sure, yes, I absolutely will. So thank you for having me again. The topic of my talk this evening is going to be about the latest updates and advances in the field of oral and maxillofacial surgery. I'm going to share with you some of the latest techniques and surgical fundamentals that we are doing at UCSF to really optimize. I have a couple. One of them. I hope to keep all of you engaged. I hope you find the material interesting, informative, educational. And I also want to, share with you some information about our department, our program at UCSF. I feel like for the last few years, at least, there's kind of been some disconnect between our department and our colleagues out here at the community. And so I want to, reestablish those relationships and share with you updates about what's going on at the university now. So this is where I work. I'm a full-time surgical attending at UCSF. This is kind of the main campus where the medical center is, as well as all the schools, the medical, dental, nursing, and pharmacy. And I spend about 90% of my time here at the hospital. Some of you may have heard back in May of 2022, they announced that they approved a plan for a new hospital at the Parnassus Heights location. These are some images of what the new hospital is going to be looking like. And they're saying that this will be done by 2030. But, given all the restrictions and regulations in San Francisco, I would not be surprised if that's not done until 2035. But hopefully it does get done. It looks like a great building. The building that's there now is pretty old, so it will be a big upgrade. In addition to spending my time there, I also spend some time at San Francisco General Hospital. This is where we see a lot of our trauma and complicated infection cases. We also have the Children's Hospital, which is a brand new hospital in Mission Bay, across the street from the Warriors Rehabilitation Center. And this is where we do a lot of our pediatric surgical cases. There is the San Francisco VA, which is got some of the best views in the city, as you can see. And that's where we treat a lot of the veterans. And finally is the dental school oral surgery clinic. And this is basically like my faculty practice where I spend about a day or so a week there. As far as who's there now, I'm sure some of you know Dr. Tony Fulro. He had a very large personality. He would come to societies and give lectures. He's essentially retired now. Dr. Brian Bast is the current chair of our department. He has been the chair for about 8 years. He's been in the department for over 20 years. Myself, I graduated from UCSF residency program in 2017, stayed on as a full-time surgical attending. I've been there for 5.5 years, and I've been the program director for about 3.5 years now. And then we have 2 other full-time surgical attendings there, Dr. O'Dara and Dr. Reed. So that makes the 4 full-time faculty at the main campus that's there now. One of the reasons why I decided to stay on at an academic institution was the opportunity to practice full scope. And, I think once you finish residency, it can be difficult, challenging to go out and try to practice and try to practice full scope. I think most oral surgeons would be motivated to do it, but ultimately a lot of them end up doing the things that you're all familiar with, the wisdom machine extraction. Yeah. Sure. 1 second, please.
I'll hold this for a minute. Okay. Okay.
Okay.
Microphone, please.
Can you guys hear me? Great.
Okay. Sorry to stop.
There you go. Is that okay now? Sorry about the interruption. So, I wanted to stay on in academics so that I had the opportunity to practice the full scope. And so this is kind of an outline of what my practice looks like. I do a lot of broad scope procedures. I do have my outpatient clinic at UCSF where I do kind of the standard office-based procedures, dental extractions, impacted teeth. When you're at a institution like UCSF, you're going to get some pretty unique cases. So it's kind of unusual to see an impacted tooth going in that direction, but you get a lot of, complicated cases, complicated patients. I also do a lot of dental implants in the dental school. One of the things I do enjoy doing a lot are zygomatic implants. These are cases where patients have severe maxillary atrophy and they're not candidates for traditional maxillary implants. So we'll place implants up into the zygoma that extend down into the maxillary lesion, and then patients can then get a fixed or a removable implant supported prosthesis. In addition to the outpatient clinic that I have, of course, I have a hospital-based practice, and this is where I get to do a lot of the surgeries that are hospital-based in the operating room.
There we go. Sorry about that. So orthodontic surgery, I was mentioning, is probably one of my favorite surgeries to do. And essentially, this is corrective jaw surgery where we are moving the jaws in patients who have a malocclusion that is not amenable to orthodontic treatment. They see the orthodontist and they're hoping that they can get traditional orthodontic treatment, but they have a discrepancy that is in excess of what can be done with orthodontics alone. So you can see patients with severe underbites, overbites, asymmetries, those kind of things. When we're evaluating these patients, I want to share with you kind of how I look at these patients, how I evaluate them. You look at them in the frontal view and you're looking for things like obvious asymmetry, excess vertical height. We're looking at proportions and symmetries. When we see them in the smiling view, you're looking at a number of things. How much of their incisal edge can you see with smiling? That could be an indicator of whether they have vertical maxillary deficiency or excess. You can see a smile like this looks a lot different from a smile like this, right? In this case, they have excessive gingival display, very narrow maxillary arch. So evaluating them in the frontal repose position, in the frontal smiling position, checking for asymmetries, cants, and those kind of things. And then looking at them from a lateral view, right? You're looking to see, do they have a flat, concave, or a convex facial profile? Is their mandible prominent? Do they have deficiency in the upper lip and the nasal anatomy, those kind of things. So you'll take appropriate photos and then you look at their facial photos. Then you advance to the intraoral exam, looking for things like canine and molar classifications, open bite, overbite, overjet relationships. And then evaluate your x-rays and take a look at those and come up with essentially a final treatment plan. Of course, there's the cephalometric analysis. One of the things I always say is that I do use the ceph, but for me, this is just a component of the full evaluation of the patient. I don't ever look at the ceph and base my treatment plan based on that. I look at the patient clinically and then, supportive information from the other data points that we have. Now, when I was a resident and up to a few years ago, the way you worked up the patient for surgery was you would take alginate impressions, pour them up, make stone models out of them, and then for a two-jaw surgery, you would then use a face bow, mount the models, and then what you do is you look at the patient, you say, okay, I think we need to move their upper jaw forward 5 millimeters. We need to move their lower jaw back forward 3 millimeters. There's probably a 2-degree cant there. So you kind of eyeball all this information, and then you would do the model surgery in the lab, simulating the movements that you planned. You'd make and then you'd set it in that new position, and then you'd make a splint that would translate all the movements you've made clinically into the operating room. So as you can imagine, there's a lot of room for error here, right? There's error in the impression taking, the records taking, and all of the steps that lead to it. Plus, the way you're evaluating the patient isn't always accurate, right? It can be subjective in the way you're evaluating them. So what's the new way that we're doing this? Now we're doing virtual surgical planning, and this was a great thing for me as a resident, especially my last year, because it meant less time in the lab and more time being able to do these cases on a clinical basis. So virtual surgical planning, he who fails to plan is planning to fail, as Winston Churchill once said. It's all about the planning. So how do we work up the patient now? So the patient is ready for surgery, right? We've communicated with the orthodontist. The orthodontist said the setup is ready. Patient's now ready for surgery. So patients come in, they get a cone beam CT scan, and then they get an intraoral scan. And then this data is uploaded to a virtual surgical planning company, and different plating companies have different planning companies. And then we do the planning virtually. So all the data is merged, and then I will be on the computer or my phone with the engineer, and then we will go through the plan, and you're getting all the measurements from all the data you provided. And so is there a 2-degree cant down this way? The lower jaw is off to the right by 1 millimeter. The occlusal plane is in this angulation. So you can get all the data with the engineer very accurately from the accurate records that you've obtained. And these planning sessions, I'm kind of like an OCD person, so these take 30, 45, even 60 minutes to complete, but they can be very quick and efficient. And if you have the engineer that you work with on a regular basis, these things can go very quickly. And now, instead of spending 5-6 hours in the lab doing this, you are able to do several of these planning sessions within a couple hours. And I think this has not only made the surgery more accurate, it's given patients, I think, better outcomes, and you have a lot more information before you go to the operating room so that the surgery can be more efficient as well. And so we do the planning, we say, okay, here's what we're gonna do, here's our plan, and then you get a report that summarizes everything. So the report shows this is your pre-op position, this is the intermediate position, meaning if you move the upper jaw, this is where the upper jaw will end up, and then this is where the lower jaw will end up once the case is done. They send you a number of different measurements from every point you can look. There's anterior nasal spine, There's the incisors, the canines, the molars. They give you the movements of every aspect from the surgery. And they have measurements to the 100th of millimeters, right? So you can see that you have 4.74 millimeters of overlap if you're impacting the upper jaw. You can take measurements of the inferior nerve in the areas where you're going to be making the cuts so that you're feeling comfortable as far as avoiding injury to the nerves as best as you can. And all the anatomical landmarks that you need during the surgery can be accurately obtained from the virtual planning. And what do you get from that? Again, is the same thing. You get splints. So you get an intermediate splint if you're doing a 2-jaw surgery. You get a splint that puts the first jaw into the planned position based on the splint. And then once that is plated and finished, you cut the other jaw and plate that into the final splint. So all the movements of the surgery that you planned are right there in the splint. So you set the patient in the occlusion and the 5 millimeters this way, 3 millimeters that way, 2 degrees of cant correction, that's all in that splint. And again, different companies have different splint designs. And then you take them to the operating room, and I apologize, I'm gonna have a few images here that may disrupt your meals here, but what happens, you take them to the operating room, you put the splint in, and then you will kind of bend plates so that you can fixate the jaw in that position. So that was kind of a really great advancement. So now what are we doing is we're using custom fitted guides and plates. So not only are we doing the virtual surgical planning and getting all the movements planned very accurately, but now the engineer is making us custom cutting guides and custom plates that actually have all of the surgical movements built into them. So it's an added level of accuracy to the point where you don't even need a splint anymore. You pre-drill the holes, you pre-drill your cuts, you separate the jaw, and then you simply put the plate on, and you can plan this to make sure that none of the screw holes go anywhere near the roots of the teeth. If you're segmenting the upper jaw, meaning cutting it into multiple pieces, you can make sure that your cuts don't go through the roots of the teeth. And then they make you a custom plate. So once you've pre-drilled the holes, you segment you cut the maxilla, you segment it if you need to segment it into multiple pieces, and then you simply line up the holes that you pre-drilled and secure the plate, and then you secure the superior holes, and now you have your movements built in to the plate. So it's an even added level of accuracy for these surgeries. And you can see, again, placing them exactly where they need to go in order to achieve your movements. You can see the plate has the bends and all the details of the movement built into it. And what they do is they go through and they identify the areas where you have the best quality of bone to make sure that you have very secure, stable fixation when you do these procedures. Different companies have different designs for these things. They can be tooth-borne. I like the ones that are bone-borne, where they actually go directly onto the bone where you're going to be doing the surgery. They have them for the mandible as well, where you can pre-drill holes and then place a custom plate that fits there. And then they're especially beneficial when you're doing chin surgery, because you can put the chin exactly where you're planning it, move it in a 3-dimensional space. They'll plan it out for you, and then they'll give you a custom plate that places the chin exactly where you want it to go. And then this is just kind of what it looks like intraoperatively, these custom plates. Is it accurate? Well, they've done studies to look at this. And this was one study done by Dr. Ellis and his colleagues. And they did find that when they compared the non-custom cases to the custom cases, that the cases that used the patient-specific implants without a splint at all were more accurate in all the 3-dimensional movements, especially the vertical and the transverse dimension. So, as healthcare providers, I think we tend to get set in the ways we do things. Sometimes we're resistant to technology and advancements, and I think a lot of us initially were, but I very quickly began to start using custom plates, and I essentially only use that now. And I find it to be efficient and accurate. When you evaluate your patients afterwards, you can see some improvements in your outcomes. So let's look at some cases of orthodontic surgery. So this is a young woman who I saw a few years ago, kind of earlier in my practice. And as you can see, evaluating them based on the views I was mentioning, looking at them in the frontal repose, in the frontal smiling, and in a lateral view, I think we can all see that she has a deviation of her chin point to the right. When she smiles, you can see again her chin is deviated and there is a midline discrepancy. From the side view, she has a relatively flat facial profile. When you look intraorally, she has an underbite, right, a class 3 malocclusion with a midline discrepancy where the mandibular midline is off to the right of the maxillary midline. And when you see that she has some chips and irregularities along the incisal edge as well. So we get our records, right? We get our cone beam, the intraoral scan, I get all this data, and then we plan her surgery virtually. So this was a fairly straightforward surgery where we're going to move her upper jaw, we're going to move her lower jaw, and set it into her final occlusion based on the aesthetic goals that we have for her. How many millimeters it comes forward, how many millimeters the jaw moves back, those kind of things. And this is still a very subjective thing sometimes where you have to decide, do I want to bring the upper jaw more forward? Do I want to bring the lower jaw more back? You sometimes have to, make a decision on those things based on your subjective evaluation of the patient's aesthetics. Okay. So again, the surgery, I don't need to go through this, but basically what we normally do is a Lefort 1 osteotomy where we cut the upper jaw, we make, osteotomies, we use mallets and osteotomes to separate the upper jaw. Same thing for the lower jaw. It's basically a controlled fracture where we get access to the areas we can get access to, and then we use instruments to actually separate the jaw and complete the fracture. And these are just some, clinical images of what that procedure looks like. So she had her surgery done. You can see in this case, we did not use custom plates, just standard plates. And this is her post-op panel. So this is her 6 weeks after the surgery. And I show this because, at 6 weeks, there's still a lot of residual swelling there, right? Even though she's 6 weeks out, we often tell people, within 48 to 72 hours, the swelling peaks and then starts to come down. But in these big surgeries, these patients can have swelling for weeks and months. And so you have to explain it to them that, yes, there's still swelling, because they'll come to me and say, do I look swollen? I'm like, yes, you do. It's okay. And sometimes they, will it ever go away? And I say, yes, I promise you it will. Some people take longer than others, totally normal. So this is her at 6 weeks. You can see we got a really nice occlusion there, a comparison of before and after. And then this is her, actually it's 3 months, but closer to 3 months post-op. So you can see in that short period of time, you have a significant reduction in the facial swelling and obviously a very nice aesthetic outcome for her. She already was debonded very quickly. I mean, within 4 months, she was able to get her braces off. You can see a very nice occlusion, midlines coincident, canines in a good position. And you can see the difference in her aesthetic outcome. There's a couple things that we classically see when we do orthodontic surgery, soft tissue-wise, and you can see it here. If you look at her nose, even though we did not operate directly on her nose, there is aesthetic changes that happen with the nose. So classically, when you bring the upper jaw forward, you will get some widening of the nasal base, and you will get some upturning of that nasal tip. And you actually can see that for her, slight widening of her nasal base and a slight upturning of that nasal tip. This is her in the smile. And again, I would say she has a very aesthetic smile now. Her midlines are more coincident. And then from a profile view, you can also appreciate a little bit increase in the nasal tip position. And that is her final occlusion from before to after. This is another case. This is a young woman who had very severe asymmetry. She had, abnormal overgrowth, condylar hyperplasia on the right side that was developing in her late teens, and it was starting to create jaw asymmetry for her. And by the time she saw me, that process had essentially burned out. So she was in a very stable position from an asymmetry standpoint. But you can see that she has an obvious asymmetry. Her chin is deviated to one side. With smiling, you can see that as well. And she also has some, like asymmetry in her orbital position, her globe position as well. And I put this picture because, people tend to try and mask the thing that they may not be happy about. So if somebody has an asymmetry that's off to one side, they'll often turn their head naturally to try and decrease the obvious asymmetry. And so, she was always just turning her head towards the right to create a little bit less obvious asymmetry in her chin. But here's the intraoral view. And again, when we show this here, you can see how off her mandibular midline is. It's almost to the distal aspect of the maxillary central incisor. So very obvious asymmetry. The key to these cases is making sure that the process that caused this asymmetry has burned out. It's complete. And we were confident that it has for her. So again, imaging that you can see how off the chin point is. And if you look at this x-ray, you can see the right condyle is definitely longer than the right condyle, which has caused this process. So virtual planning, as we discussed, and we got all the measurements. The thing I'll point out here is that if you take a look at that bottom number over there that I highlighted, her chin point is moving to the right almost 14 millimeters. So it's a very significant movement. This is her panoramic radiograph after the surgery is done. And again, now you can see that her midlines are coincident. Big movements here, especially on that left side. You can see a big gap in the cut there. And this is her 6 months afterwards. And when you see her, obviously this is her natural head position now. So she is actually, when we asked her to just look straight and be comfortable, she is now looking straight. She's no longer turning her head. And you can see she's, again, has a very aesthetic smile, not a big significant change in her profile because her profile wasn't, a big thing that we were trying to correct here. And you can see her occlusion, very nice occlusion, maybe a slight movement to the left of the midpoint, but overall, very nice occlusion. And you can just see her before and after. And if you pay attention to this, you can even see that her orbital asymmetry has corrected or improved. And I think some of that just has to do with when you move the skeleton that much, the soft tissue changes can also have an impact in the areas where you're not working. So for her, you can see the orbit and the eye looks more symmetric now when you look at her. Her in the smiling position, and no big difference, not severe changes in the lateral view, but and then her occlusion, right? A huge change for her. And these cases obviously are not possible without good orthodontic treatment. Let's look at another case. This gentleman, he's one of my favorite patients. Really nice guy, very friendly, always thankful. He's one of those people that, if you have a horrible complication, he would just say, well, you did your best, doctor. It's just fine. Really nice guy. If you notice some of his facial features, he's got some coarse facial features, right? He's got a very large jaw, he's got a large mandible, very thick, coarse facial features. And you can see he's got a significant class 3 malocclusion, a big underbite. That's a big underbite. And turns out that he has a history of a growth hormone producing pituitary adenoma, which led to acromegaly. And so, I'm sure you guys remember your medical knowledge of acromegaly, but it's actually a very important disease to be aware of. Not that long ago, a general dentist referred me a patient who they suspected had acromegaly. And that patient was referred to their primary care doctor, had the appropriate testing done, was diagnosed with the pituitary adenoma. So just having a level of awareness and suspicion can make a huge difference for your patients. And that was a really big deal. It actually wasn't even picked up by their primary care doctor. So, there are some classic facial features that you look for in patients with acromegaly. Enlargement of their hands, their feet, their tongue, the development of an underbite. If they had an underbite, it continues to grow past the age of growth, right? If somebody says, I'm starting to develop an underbite in my 20s, that's not normal, right? So those are things you want to be paying attention to. So he had orthodontic treatment, was properly worked up, and then he came to me for the surgery. And if you pay attention to his maxilla and his mandible, if you look at his mandible, it just has a very unique shape to it, right? It has flaring down at the angles, but yet it's very thin in the areas where we normally make our cuts for these surgeries. So instead of doing a traditional cut that I normally do for the lower jaw, we plan to do something called an intraoral vertical ramus osteotomy. Essentially what you do is through the mouth, you just make a cut in the ramus on both sides. You put the patient in their final occlusion, and then that's it. You don't use any plates, you don't use any screws, and you leave them there for a few weeks in MMF, in heavy elastics, and then you release them and you basically train them into their occlusion with guiding elastics. So you can see we did custom. This was the case we did use custom guides in place. So we used custom guides here in this case. And then for the mandible, I asked them to make me a custom guide for this intraoral vertical ramus osteotomy. It's a really difficult cut to make. It's all the way back there. It looks, when the planners do these, sometimes they say, oh yeah, let's put it here, and then let's put the guide, wrap it around here. We can go all the way here. And then you as the provider are all excited. You're like, yeah, that's a great idea. That looks really good. And then you go during the surgery and you go, how in the world am I going to fit this thing in here, right? So that happens a lot. And so doing these cases, custom cases, has a learning curve to it. You have to start to figure out what is possible and what is not possible, because engineers are not clinicians. They're just designing these nice fancy guides. And so, we had this guide made, and this is what the IVRO is. We literally make a cut just behind the lingula where the foramen is, making sure not to hit the nerve. And then once you cut it, you split it, set the mandible backwards. You can only do setbacks with this. Put them in their bite, and that's it. You leave them there. And I don't do many of these, I'll be honest with you, but we felt like we had to do it in this case. So this is intra-op photos, and you can see the custom maxillary guide is in place. We pre-drilled those holes, we pre-drilled the cut. And then this is the custom maxillary plates in place. And then we did the mandibular surgery and put him in his bite. And this was like one of the first times I've seen Dr. Pogel do this a lot, but this was the first time I did it. And he came back in about 2.5 weeks, and we released him from the heavy elastics, and I had no idea what to expect. But thankfully, his jaws kind of stayed put. He was opening and closing the same spot. So this is him at 6 weeks out, and you can see, okay, it's looking pretty good. Usually they'll lose some weight after this surgery, but he was only banded closed for, again, 2.5 to 3 weeks at most. And then afterwards, we rely on guiding elastics to help maintain where his occlusion is going to be. So you can see, hey, his bite's looking pretty good here, right? I mean, he's got midlines coincident. You see I have the rubber bands in place to help guide him into his occlusion. So things are looking good. Look at the pano. I mean, this looks weird to me. I'm sure it looks weird to all of you as well. What we're trying to have is actually this. We need this to happen, where you make the cut, that condylar segment sits lateral to this dentate segment, and they overlap each other. And the overlapping allows these two to eventually fuse and heal without any plates or screws. This side actually is not ideal. You don't want them to just be sitting passively next to each other. So I was told that, hey, this might be a problem. So, but we just let him do his thing. And then this is him 6 months afterwards. You can see the US flag tank top. Really happy. He's obviously lost a lot of weight. And like this picture really is a good example of who he is. Just a happy, positive, excited person. He was really happy with his outcome. He had no numbness of his lip or chin, because that surgery does prevent injury of the nerve. And you can see his occlusion. Everything stayed really put. The midlines are coincident. He's got, again, good occlusion. Everything looks like it's contacting well. You can see him before and after Obviously lost a lot of weight. Big smile, happy. He's definitely smiling bigger now, right? And then from a lateral view, you can see a big change. And then, comparison of his malocclusion before and his final occlusion once the orthodontics were completed. Okay, one more of these orthognathic cases. This is a really interesting one. So this is a young gentleman who came to see me after having been seen by multiple other providers. And, everybody basically told him that, look, we don't know what to do. We can't treat this. This is really complicated. The movements are too extreme. You should go somewhere else. So it took him a long time to eventually get a surgeon, find somebody. This is a pretty severe case, right? You can see that his upper teeth are severely flared. He has a severe retrognathic mandible, his mandible setback. And, he might not say it, but his parents came to me and said, he's very self-conscious about this, obviously. So he was seen at the UCSF orthodontic clinic. And, a lot of this case is orthodontics. This cannot be done with excellent orthodontic treatment. And the orthodontist did an amazing job just to get him orthodontically prepared and ready for surgery. But, this is very intimidating for a provider to have to deal with. But I look at these cases and I say, well, you know what? If we're not going to do it at UCSF, then who is, right? I mean, we're the people that our colleagues are referring to because they may not feel comfortable with it. And so I've said this before, I tend not to say no to my patients when it comes to treatment. I usually am saying yes. That doesn't mean I say yes to all treatment. And sometimes I tell people, no, you do not need this surgery. Don't get it done. But I don't like to say, no, this is too tough for me. Go find somebody else. I find these cases to be challenging. They're difficult, but think about the impact you can have on their life if things go well. So I said, absolutely, I can see you, no problem. So he went through his orthodontic treatment. You can see it's a process, right? So this is where he's starting from. All the colors mean things are really off there. So he underwent orthodontic treatment, and you can see little by little, they're starting to get things aligned properly. Oh, hi. Yeah. Yes, he did, as a younger child, yeah. No, we did not. Yeah. Yeah, we actually have one of our colleagues at UCSF. He talks a lot about like subapical osteotomies and procedures to just set back that anterior segment. Right. Yeah, thank you for that. I mean, this is what we did in this case. So you can see, just look at how narrow his maxilla is, right? And eventually, ortho was able to get him, really nicely set up. They were able to retract those teeth orthodontically, not surgically, but they were able to orthodontically get those leveled, aligned, coordinated. And so we planned his surgery. When he came to me for the surgery, he said, my insurance is going to run out in about 6 weeks. Can you do the surgery? And I said, yes, right? I usually just say, yes, I will. And he still had his wisdom teeth in place. And the orthodontist said, he's not there yet, but I will get him there after surgery. I said, yes, okay, let's do it. I can't leave him, right? So I got to do it. So he had his wisdom teeth in, but we still planned the surgery. And as far as wisdom teeth goes, I have no problem taking out wisdom teeth at the time of surgery. It's not a big deal. But if we have the opportunity to have them removed 6 to 9 months before, it's preferable. Now, I want to show you his measurements for the surgery. So first of all, you would say that his maxilla was too long, correct? So we plan to impact his maxilla 1 centimeter up. 1 centimeter, I'll just say that's a big movement. The mandible is coming forward 18 millimeters. And on average, I would say most people will move the mandible forward 8, 9, 10 millimeters. So this is an extreme movement. His chin is coming forward 23.5 millimeters. This is without a genioplasty. We're actually not touching his chin. I wish we did a genioplasty because I'll show you in the after photos, but just with the upper and lower jaw surgery and rotations of the jaw, the chin is coming forward 23.5 millimeters, which to me at the time seemed like a whole lot. And then another thing here, excuse me, we're expanding his upper jaw 14.5 millimeters, which is a lot. Usually, we'll say surgically somewhere around 6, 7, 8 millimeters. Beyond that, you need to do, surgically assisted palatal expansion, like distraction. But this was all, I had to work with. Oh, thank you so much. So a lot of extreme movements, and we took him for surgery. Everything went fairly well. We took out the wisdom teeth. We did the upper jaw in 3 pieces, the lower jaw, everything came forward. And this is him immediately after surgery, a few weeks later, swollen, but feeling good. And then his occlusion, and, he was in orthodontics for a while after the surgery, because when you do movements this extreme, you really need to control things to minimize the amount of relapse you're going to get. And so you can see that there's a transpalatal arch wire there, but you can tell how much expansion we got if you compare his maxillary arch form now to what it was before. And things are progressing orthodontically. And this is, about 9 months or so after the surgery. Things look to be healing. The hardware is in place. No major issues there. This is him 20 months afterwards. And you can see, a significant difference in his facial appearance here. He's getting close to finishing his orthodontic treatment at this point, almost there. And then this is him finally 2 years post-op. He decided to grow a beard, got a little, messy there, but obviously a significant, I would say, life-changing impact for him. If you look at his occlusion there, with what we were starting with to where we ended up with, it may not be perfect. And if you also notice, he only has 2 lower incisors, not 4. So things may not be perfectly interdigitating, but the ortho was able to do a great job. And just look at him before and after. I mean, you can't even recognize him. He's a completely different person. And he was kind of a stoic guy, but his mom was obviously incredibly emotional about this. And that was really rewarding. When you do these cases, yes, they're difficult, but when you're able to get the outcome you're hoping for, it means a lot to me. I mean, this means a lot to me to be able to do something like this for him. And it, keeps me going to want to take on cases all the time, challenging cases. So you can see. Now, this is why I say I would have actually liked to have brought his chin even more forward. Even though that came forward 23 millimeters, he could have used the genioplasty to bring that chin another 6, 8 millimeters more forward. But at the time, I thought 23.5 millimeters, I was worried his chin was going to be too prominent, but that rarely happens. Okay. Any questions about that? Any questions at all? Hopefully you guys are finding this interesting. Yes. I don't think it's on.
Patients experiencing post-op.
I missed the last part.
Airway issues, so their breathing ability and all the rest. Post-op.
Yeah, their airway,
There's kind of an echo now.
their airway
Significantly improves. In fact, a lot of times people are doing maxillary expansion surgery. In fact, you guys were going to have Dr. Liu here, who's probably going to talk about expansion to improve the airway, but widening the airway, as you mentioned, does improve their breathing. And he did not have a formal sleep study, but I can promise you that bringing his jaw forward 18 millimeters and expanding his jaw that much completely opened up his airway. So yes, that's a good point. Any other questions before I jump into everybody's favorite topic, TMJ surgery? Yes. I would say 100% of the time when I do mandibular surgery, not the IVRO that I showed. The IVRO's one advantage, one of the advantages, is that it usually avoids paresthesia. But the standard osteotomies I do for the lower jaw, I tell them 100% of the time, you're going to have numbness after this. The question is how long? And the patients always say, is it permanent or temporary? And obviously it depends on a number of things. It depends on how the surgery went. It depends on the anatomy, and it depends on their age. So what I've noticed is that, and the studies show this, that patients that are over 40 years old and are having surgery, whether it's for orthodontics or for sleep surgery, they tend to have a higher risk of having long-term numbness, paresthesia. And those patients tend to notice it more. It bothers them more. Whereas patients in their late teens, early 20s who are having the surgery, they have a lower likelihood of having long-term numbness. And even when they do have long-term numbness, I almost have to ask them, as opposed to them coming in and saying, hey doc, this is still numb. Did you know that? I say, yes, I told you it would still be numb, you know? So age plays a factor, but immediately after surgery, all of them have numbness. The upper jaw is also always have numbness, but that goes away within a couple of months on a consistent basis. Yes. Yeah. So these patients that I'm seeing have medical insurance. So we bill medical insurance, and whether it's United Healthcare, a PPO plan, or it's Medi-Cal, we will see these patients. We get all the records, like the presentations that I'm showing you. We put these together, and then we submit them for pre-authorization to the insurance company. And 95% of the time, they'll get authorization. And for Medi-Cal patients, they usually won't really have an out-of-pocket cost for this, so it's a good thing. Some insurances will have a percentage that they'll have to pay, like their deductible or something like that. That's why sometimes it's difficult to get the ideal aesthetic outcome, because the genioplasty, the chin component, is usually not covered by the insurance, because the insurance will say this is cosmetic. And so then we have to go to the patient if we think it's going to benefit them and ask if they're willing to pay out of pocket for it. Sometimes they will, sometimes they won't, but a lot of times we won't do the genioplasty because of insurance restrictions. I saw another hand raised. Yeah. Yeah. So females in general tend to end facial growth younger than in males. So for females, it's around 15 years of age. For males, about 17 to 18, but sometimes even later. I've seen cases where people in their early 20s are still having some residual mandibular growth. And there's a number of ways of doing it. I personally like to just look at serial lateral cephalograms and look at the position of the jaw over a 6 to 9 month period. But there's other things like hand wrist films, there's cervical spine evaluations. I like serial cephs. Yeah. You guys okay if I keep going? Okay, I'll try to make this interesting, I promise. So TMJ, obviously it's complicated, right? Not everybody's interested in managing TMJ patients, and I totally get that. And you know, this shows you that when there's so many people that think they've got it figured out, it's probably a very complicated disease process. And so you can see there's a lot of people, from general dentists to surgeons, orthodontists, prosthodontists, orofacial pain specialists, and then also, you know, non-dental related acupuncturists, chiropractors, psychiatrists. So TMJ is complicated. I totally get that. And the patients are complicated, not just the management of the disease process, but the patient can be difficult as well. It can be challenging. The way I like to think about TMJ disease, to keep it simple for myself, is I break it down into 3 categories. And I call it myofascial pain, like is it related to the muscles? Internal derangement, which is it the disc? Or osteoarthritis, is it degenerative arthritis? Is this a bone problem? When it comes to myofascial pain, this is a situation where you ask the patient, if you take your finger and you can point to me where that pain is? And a lot of times they'll point here and they say, and then it goes here and here and down here. And when you do your exam, you can oftentimes, not always, but oftentimes feel tenderness in the muscles of mastication. There can be trigger point areas as well. And so this is kind of the general category of myofascial pain. And for this, usually conservative management is best. For me, once they've kind of exhausted the soft diet, the NSAIDs, the muscle relaxants, those things, I actually like to treat them with Botox injections where you do about 30 units into the masseter, 20 units into the temporalis, and a good portion of patients actually find good relief with this if the problem is myofascial in origin. The problem is that these things don't exist in isolation, right? Most people don't come to you perfectly packaged as this is myofascial pain. There might be a component of myofascial pain, but they also have other, internal derangement or arthritis going on as well. Then there's internal derangement, and this is basically the disc and the function of that joint. There's something disrupted, and this is when patients are coming in with clicking, popping. Sometimes it's painless. Sometimes they're having pain. They may have limitation of mouth opening. They might complain of lockjaw, those kind of things. So that's classically internal derangement. And the 2 categories I like to think of them as are anterior disc displacement with reduction and anterior disc displacement without reduction. And if you look at it, this always makes it easy for me to think about. At rest, that articular disc is sitting anterior to the head of the condyle. And as they start to open, initially there's a rotation and then there's the translation. And as it translates forward, that's the pop or the click where it pops into the disc. And then as they close, it pops back. So the disc is captured and then recaptured. That's why they're hearing that clicking and popping. So this is anterior disc displacement with reduction. Without reduction is oftentimes a progression of that disease process, where now the disc is in front of the condyle, but it stays in front of the condyle throughout the jaw movement process. And so it's almost like it's getting, compressed anterior to it. And so patients in these situations will sometimes say, my mouth opening was okay, I had this clicking and popping, and then it stopped, but now I can't open as wide as I used to. And because that disc is preventing maximal translation of that condyle. This is kind of a summary of what a normal movement looks like, what ADD with reduction looks like, and what ADD without reduction looks like. The best imaging to capture this, aside from your clinical exam, the best imaging would be an MRI. And you can see it nicely here, anterior disc displacement with reduction. If you see the condyle at rest, the disc is in front. As the patient opens, the disc is captured and is now between the condyle and the articular eminence. In ADD without reduction, the disc stays in front throughout the whole opening and closing cycle. So what do we do for this? There's non-surgical treatment still for this that can work, and I like to refer patients to an orofacial pain specialist to at least try that as an option, because you don't want to jump to surgery right away. Once you commit to surgery, it can be a big deal. So I still try and manage this conservatively. Once it gets past that point and surgery or some type of intervention is necessary, these are the common things that I would recommend for the patient. The first one is arthrocentesis. Basically, all you're doing is placing 1 or 2 ports in that superior joint space, and you are flushing the joint out with some type of isotonic solution like saline. And the idea is that you're eliminating those inflammatory components in the joint, you're changing the dynamics in there, and maybe the condyle will now be, and the disc will slip back into the right position. This is minimally invasive, can be done in an outpatient setting or in the operating room under sedation. And these patients tend to do pretty well. The problem is this is not permanent, and over time, they will start to complain of the symptoms again. Then there's arthroscopy, where you actually take a camera and you place it into that superior joint space. Now you can see what's going on there. And the people who are really good at this, that does not include me, those people can take a look, make diagnoses inside that tiny little space, and then they can also fit tinier little instruments in there and start doing surgery in there. I mean, it's amazing. Again, that's not me. But what you can do basically is just go in there, evaluate it, and then you can irrigate it, just like arthrocentesis, and then you can inject some steroids and bupivacaine or something to at least help with the symptoms. So this is another option. If they've not succeeded with that, and now you're going to do surgery, there's a couple things you can do. There's disc repositioning, where you go in there, it's an open surgery, you make an incision, you actually grab that disc that's too anterior and you pull it back so that you've repositioned it back in the correct location. Or you can remove the disc. You can just say, okay, this disc is perforated, it's damaged, I'm just going to take it out. Either I'm going to put nothing there, or I'm going to put fat, like abdominal fat. You take a little bit of fat, you pack it there, or you put cartilage from the ear, or what I like to do is do what's called a temporalis flap. You just take a small portion of the temporalis fascia and muscle, rotate it into that disc once you've removed the disc. And it tends to work really well to improve patient symptoms. So that, yes. Stem cells, not me. At the VA, they're doing a lot of innovative things with TMJ. They've done things like injecting Botox in there. Sometimes what you can do in these cases is you can use a cartilage allograft, like cadaver cartilage, and then put like an amniotic membrane, which is kind of like, you know, stem cells in that area. So that is also one of the possibilities. So those are the two categories: myofascial pain, internal derangement, and then you have arthritis. And in this situation, this is when people are having a lot of pain. There's crackling or crepitus in the joint, and the disease process is obviously advanced pretty far here. And if it's really bad, they can develop ankylosis. You know, they get so much excess bone because your body's trying to repair this. So it'll start to lay down more bone, and eventually you can get ankylosis, meaning the condyle starts to fuse to the skull. The CT scan, you can see there's the characteristic findings of arthritis on the CT scan here. There's flattening of the condylar head, there's narrowing of the joint space, there's subchondral cysts, and you can see some osteophytes. This is what we call bird beaking, where you get excess bone forming there. What do we do about that? I never treat an X-ray alone. Sometimes you'll get an X-ray, you see the patient, and those two things don't match. The X-ray looks like their condyles are completely flat. They should be in agony all the time. And then you see the patient and they have perfect range of motion and they have no symptoms. What do we do? Nothing. Nothing at all. You leave them that way. You just let them know, but sometimes you don't even let them know, because then they start to think about it and say, wait a minute, I think I do have pain. What's going on here? So, you know, no surgical intervention. When do we do surgery in these cases? When it's a problem. When they're having symptoms, when their function has now been limited. And what are we doing for this? We're doing total joint replacement surgery. Now, total joint replacement surgery has a bad rap, because for a while back in the 80s, there was a lot of total joints of the TMJ being done, and they were having really horrible outcomes. They were using things like metal on metal articulation. That's a problem. They were using Proplast Teflon interpositional components, and these were causing a lot of problems for the patients. These patients were having these giant cell reactions, a lot of pain, a lot of swelling, and the FDA actually removed these products from the market. And so you can imagine this has been going on for a number of years, and all these patients are having these horrible failures and outcomes. Like, this is a foreign body giant cell reaction from the removal of one of these prostheses. Look at that. I mean, that's horrible. So the general thought process was total joints don't work. I mean, this is horrible. But over time, the technology has significantly improved. And right now there's two companies, there are two types that are making total joint replacements You can see one of them is a stock TMJ replacement by a company called Biomet. They received FDA approval in 1995, and then the custom joint company, TMJ Concepts, now purchased by Stryker, they got FDA approval in 1997. These are very effective treatments for patients who have severe degenerative disease, who have ankylosis and these other problems, and they work. They work really well. This is an example of the stock prosthesis. What does that mean? It means the patient needs surgery. You can take them to the operating room. They have, 3 sizes, basically like a small, medium, large fossa, a 45, 50, or 55 millimeter condyle, and you just kind of fit it in there. And a lot of times these work well. I will use these from time to time, but it requires some work, right? You got to trim this, smooth this down. The custom TMJ, these are made for the patient. So you get a CT scan and all the records, you send it to a company, and then they are going to make a custom prosthesis made up of a titanium mesh here with a polyethylene fossa, and then this titanium alloy with cobalt chromium head. And this is made specifically for the patient, fits really well, and it is like a total joint replacement for a hip, for a knee, for a shoulder. We're doing it for TMJs, and these are working very well. Now, we talked about custom guides for orthodontic surgery. They have custom guides for this too, where you can mark the cut, pre-drill your holes. It's like custom on custom. So you got custom, and the custom holes are pre-drilled there. So let me show you a couple cases. This was a gentleman. He's in his 50s, and he is an engineer for a big commercial airline company. He's been living with pain for years, and he's seen a number of specialists, and eventually ended up with me and said, look, I'm taking a ton of narcotics, and I can't focus on my work. And I said, that's absolutely unacceptable. If you're making it plane safe, you cannot be taking narcotics. Like that's not a good thing for him and not a good thing for any of us. So I saw him, and if you evaluate, this is his bite, a very deep bite. It was even hard for him to get all the way into his bite because he had a deep bite, but he was totally comfortable with this bite. He said, I don't want to change nothing with my bite. This is not the problem. The problem are my joints. And again, you can see very severe degenerative arthritis. He had tried all these conservative things. Conservative things will not work for this. Once he becomes symptomatic, conservative treatment is not going to do much for him. It might reduce the symptoms a little bit, but it will not treat this. So, the custom joints, as we talked about, we made him bilateral. The plan was bilateral TMJ replacement for him. And so the prostheses were fabricated. This is him in the operating room. The setup is kind of fancy. You know what I mean? There's a lot of preparation. You got to do nerve stimulation to make sure that you're not injuring the facial nerve because you're working around that. You got to love his tattoo there. Nothing but blue skies or something, tailwinds here, a nod to his aviation background. And then, the surgery. So we make 2 incisions on either side, one right here in front of the ear, one right down here by the neck. They're not connected, they're separated. Go in, remove everything that's not healthy, clean everything out. And then, these are the remnants of the condyle and the disc. And then the prosthesis is placed. And there's a certain way that this needs to fit, where the head of this needs to fit on the posterior slope of that fossa. That tells you it's in the right spot. And then, that's in place here. And afterwards, this is his x-ray. You can see his joints have been replaced. You can't see the polyethylene fossa on the x-ray, but it's there. And he did really well. I mean, he basically told me that, this changed his life. He was off of his narcotics. He was able to function normally. He was able to go back to work comfortably. And he said, look, if any of your patients ever are thinking about doing the surgery, have them call me. I'll let them know. This was several years ago. I haven't heard anything from him. He's doing well. And that's how the incisions heal. Now let's look at this more extreme case. So this is a young woman who has what we think is idiopathic condylar resorption or juvenile idiopathic arthritis, one of these two. More likely juvenile idiopathic arthritis. It's basically like arthritis in pediatric patients. And you can see she has severe crowding, class an overjet, severe overjet there. And if you look at her condyles, they are non-existent. They've completely resorbed. And you can see them here in the 3D view, right? No condyles, basically resorbed down to the sigmoid notch there. You can see them there. So this is her Steph, and you can see one of the big things, and we'll show this again, is how steep her occlusal plane is. You had mentioned airway. Look at her airway. And now, sometimes I get patients refer to me, and they said that I was told I have sleep apnea because my x-ray showed a very narrow airway. And you cannot formally diagnose somebody with sleep apnea simply by seeing a narrow airway, because again, you might see this on an x-ray. They go and get a sleep study, and they actually have very mild or minimal or no sleep apnea. But in this case, very narrow airway, difficulty breathing, all those things. And that is consistent with her facial appearance, right? So this is her before surgery, new hair color, but she has essentially no mandible here, right? And this is very nice job, again, by the orthodontist, getting her properly set up for surgery. This is the skeleton. And so what are you seeing here? As the condyle resorbs back, everything starts to rotate in a, what we call a, kind of a clockwise rotation. So if you look at her from this side, look at the occlusal plane. It's completely pointed downwards, and everything is sloped, because as the mandible goes, the maxilla is going with it, because this was happening at a young age where things were moving together. So the plan was for her, because she was also having limitation of function with her joints, some pain. So we said, well, the only way to do this is we're going to replace your joints. And in the process of replacing your joints, we're going to move everything. So we're going to do a combined TMJ orthodontic procedure for you. So this is the plan. You can see a big rotation of the mandible and the maxilla. You have to do both jaws, obviously, because if you just move the mandible, you're going to have a huge open bite in the back. You can see her occlusal plane change there. And this was a while back for me, and it was, when I look back now, I almost wish I would have even flattened her occlusal plane even more, but it was still a huge movement. It was about 25 degrees or something. So this is her taken to the operating room. And, standard intraoperative photos. Now, one of the interesting things here, if you see this, we did the mandible first. When I first put this splint in, this is all I got. So I had to, like, little by little squeeze this more, put more wires, bring it. It took about 20 minutes to stretch the tissue enough to rotate her mandible from there all the way to here. And you can finally see it there, how it's fitting in the splint. Once it's in that splint and in the right position, the custom joints go in place, and they should fit accurately if you put them in the right position. This is some abdominal fat. I mentioned we take a little bit of fat from the abdomen and then pack it around the joint to minimize excess bone formation. And then this is her with the maxilla also. So this is her skeleton afterwards. So you can see here, the joints are there. Look at how much her jaw is rotated in that position, the before and the after. I mean, I like to show her chin was at the level of her arch, and you can see now the chin is here at the level of the orbit. It was planned to also do a genioplasty, but there was so much movement that we decided not to. I really wanted to do a genioplasty for her. She actually, after the surgery, decided against getting one done because she was happy with it. And this is her 10 weeks afterwards. New hair color again, some changes to her makeup, obviously. She was probably 19 or 20 years old. And, obviously a huge change for her. Like, just look at her facial appearance here. When you look at her from a lateral view, I really would have loved to have done, again, a genioplasty to bring this out even more. But she was not having any of it. She said, this is more than enough. From where she started, she was very happy with where she was. And you can just see the comparison of her before and her after. And this is just 10 weeks afterwards. Her smile there. She had a very long maxilla. We obviously impacted that. And I think we could have done a better job with the profile, but still a nice one. Okay, this is the last case. And this is another really complicated case. So this is a lady who was referred to me for severe obstructive sleep apnea. And she, again, had seen a number of providers. We presented her case at our department's meeting, and we presented her case at our combined meeting with our ENT colleagues, and everybody said, no, she is not a surgical candidate. She's too complicated. She's too sick. She had a history of strokes. She had severe acid reflux, cardiac issues. There was a lot of things going on for her. And so, I was kind of scared away. I said, let me think about this for a while, right? And then she called me and said, please help me. And then, I said, yes, of course I will. So this is her bite. I actually referred her to an orthodontist, and then the orthodontist referred her to a periodontist, and then referred her to a prosthodontist. And everybody said, this. So she called me and said, do I need to have ortho? I said, forget, it's fine. It's fine. We'll just do this because this is really important for you. We have to do it. So that was the bite we were working. Again, look at her conduct. What happened? She had orthodontic surgery done, and these are old wires that were used to fixate the mandible back then. She had orthodontic surgery done in her teens, and over time, she developed severe resorption of her condyles. They also used a chin implant at the time, which I'll show you. But look at her condyle. So you can see that there's a chin implant right here. And then this was a look at her airway. So the airway measurement was showing an airway of about 4 millimeters, which again, I said, doesn't always correlate with the severity or the presence of sleep apnea. Now, this was her sleep study. And her AHI, which is the apnea-hypopnea index, was 123. As a form of reference, so when you get a sleep study done, in order to quantify the severity of the sleep apnea, they look at your AHI, basically the number of times you have an apneic, which is complete absence of breathing, or hypopneic, which is a reduction in breathing, the number of times you have an apnea or hypopnea per hour of sleep. 5 to 14 is mild, 15 to 30 is moderate, greater than 30 is severe. Hers was 123. That means 123 times per hour she would stop breathing. And she would sleep in a chair. She basically told me that I haven't slept in like 8 years. So this was a severely debilitating thing for her from a sleep standpoint. But it was obviously aggravating her other health issues as well. If you're not getting sleep, it's going to cause other issues like cardiac and kidney and all these other things. So this was a complex case. And as mentioned before, I was hesitant, but in the end, I knew that if somebody's going to do the surgery, I'm going to do it. So we decided to proceed with surgery despite her poor dental condition and all the other things. And this is just the plan. And the big thing to note is that we are doing a huge counterclockwise rotation of the mandible and the maxilla because things are over-rotated there. And you can see that once we're done, the occlusal plane is quite level, but it required a significant rotation to get us there. And there's a lot of numbers here, but the big thing to point out is that the chin is coming forward 34.5 millimeters without a genioplasty. Just the rotation and advancement of the mandible brings the chin forward 34.5 millimeters. Take a look at the design of these prostheses. I mean, you can just see the mandible is 2 centimeters in front of where the fossa is supposed to be because of how forward we need to bring everything. So you see that S-shaped design of the custom joint. This can only be done with custom CMJ replacement. Intra-op photos, and then this is the 3-dimensional reconstruction of our results. And I think we really got a good result here. We were able to make the movements that we were planning. It was incredibly hard. Again, it took a long time to just be able to mobilize the mandible enough to bring it forward, but we were able to do it. And then if you look at the airway measurements, he went from 4 millimeters to over 19 millimeters. This is her the next day in the ICU. We took her to the ICU because the surgery was so long. I slept better than I have in years. And I told Saghezchi that he could do anything he wanted except make me ugly. It worked. So this is her 5 months afterwards. She did have some weakness on the right side of her face. which eventually resolved, so she did not have any residual weakness afterwards. And, you know, you can see she has a change in her profile. Yes, her chin is very prominent because of that chin implant, but you can see the lengthening of that chin point and the opening of her airway. The before and the after. She had a sleep study done, and I can tell you that, you know, when she came and saw me a few months later, she was normally coming in with a walker. She no longer came with a walker. She was walking normally. Her blood pressure had improved. She was feeling so much better. And everything was going well. We eventually had a sleep study done for her. She had an AHI of 123. Her new sleep study came back as 13. Obviously, that's a huge, significant drop in her AHI. And in the AHI, none of the events were apneas. They were all hypopneas. Whereas her previous AHI had over 80 apneas. This time she had none. So that is the end of, I'm sorry you guys missed that, but that is the end of my presentation. So are there any questions? Yeah. What is your opinion on photomodulation therapy for myofascial pain in PMD? Honestly, I don't know anything about that, so I can't really comment on that. I think there's other questions here. No? Anything else?
Most of the other questions were about the audio and visual problems and about the keyword, which I will go ahead and present.
Hopefully people were able to hear the end of this. I apologize for that. This is quite tricky to try and navigate an in-person and a Zoom lecture at the same time. Thank you for your patience, everybody. I really appreciate it.